Team is here actually. Yeah. So welcome everyone. It's my pleasure to introduce Eric Bryant from New Jersey Department of Health, and because we are, as Philadelphia Regional Center of Children's Environmental Health, we really run program focusing on children's environmental health. And Eric is a co-founder and the lead of New Jersey Department of Health Biomonitoring and Exposure Assessment Program, and is also the founder and the lead of the prenatal screening program. So prior to leading this program, he actually ran the New Jersey Department of Health Metals Laboratory testing for mercury and other elements in clinical, environmental, and food samples. And he currently leads multiple projects biomonitoring the New Jersey population and vulnerable subpopulations, and is designing a mercury tracking program to help respond to mercury crisis that New Jersey Department of Health actually identified. He actually previously worked at Maryland Department of Health and Hopkins and Harvard doing research in chemical and molecular projects and working on his master's degree in public policy actually before American University. So he currently serves on the Delaware River Basin Commission of Toxic Advisory Committee and the past chair of the Public Health Representative on the American Public Health Laboratories Environmental Health Committee, and as a chair of member of multiple environmental health, food and toxic elements, and biomonitoring focused subcommittees and work groups. He actually advocates for increased biomonitoring awareness, collaboration, and funding at the state and national level. And welcome, Eric.
Much. Thank you. So it's a pleasure to be here to talk about our work, specifically on prenatal screening for lead and mercury. It's actually prenatal and perinatal screening. We'll get into that very shortly. I am from the Department of Health, Public Health Environmental Laboratories, within that chemistry and within that biomonitoring exposure assessment program. I do have no conflicts to disclose, and I want to state that these opinions I share are my own, do not necessarily reflect those of the New Jersey Department of Health or the CDC. Okay, so for those who don't know what biomonitoring is, it's basically the measurement of chemicals in people. We're exposed to chemicals every day in everything that we do. It's in the food we eat, the water we drink, the clothes we wear, the furniture we sit on, the air we breathe. I've updated this slide to include the hand sanitizers to look at COVID and that response. And some chemicals are good for you, some of them are bad, and some of them are really bad. Why do biomonitoring in New Jersey? We have a lot of good reasons to do biomonitoring in New Jersey. One, we're the heart of the Northeast Transportation Corridor between the rail lines, the highways. We have the shipping corridor for up the Delaware as well as on the East Coast. We also have some airports within New Jersey and right within our borders. Shared waterways, as I mentioned, Delaware River, we share with Pennsylvania, of course, Philadelphia right here. We have the highest concentration of and number of Superfund sites in the country. In addition to those, we have about 16,000 additional hazardous sites. Not only do we have the airports around, we also have things like the coal plants that bring smoke over. Mercury can travel up to 2,000 miles in the air. So anything from forest fires out in California to regional ones to local ones can affect our population. We also have a very diverse population in general, and you'll see that some of those factors come into play as well. Just very quickly going to touch upon some health disparities. There are a lot of causes. You can read them here. I'm not going to go through them. A lot of these will pop up as we go through and look at some of our examples. To highlight, it does result in delayed healthcare, especially the first prenatal visit, and leads to negative health outcomes in general. In New Jersey, we had the nation's largest disparities in terms of Black maternal and infant mortality rates. That has improved significantly. We were ranked 47th for maternal outcomes. That's improved a lot since our administration came in, especially our First Lady and our department focused heavily on maternal wellness. I will say that in terms of maternal mortality, 60% are women of color. Keep that in mind as we look at some of our populations here that we're testing. And 1% of Black babies do not live to see their first birthdays. As is often the case, many with the greatest need for access to public health services as well as medical care have the least access. And these are also the ones that are very likely to be exposed to chemicals in general. Okay. This work was based off of a collaboration we had with Dr. Wong's group at the Johns Hopkins School of Public Health. She has been running the Boston Birth Cohort for decades. It's actually the longest continuously funded cohort in the country. Mothers and babies are enrolled at delivery. They've collected various samples from them, including blood samples. And in the case where the babies get treatment at the hospital, they've been able to follow them throughout yearly checkups and up until their 21st birthdays. So they have a ton of data and a lot of outcome data as well. And all they had, actually, they're still going. So they have over 9,000 mother-baby dyads. And the work has been very fruitful in terms of publications, in terms of data, in terms of new science. And you should feel free to accompany these articles that may interest you. Okay. They came to us when I was in Maryland, looking to understand the heavy metals exposure in this population. It is an inner city, so an urban population, low income to medium income, very diverse, mostly minority. They focused on babies that had preterm birth, but also had a nice large control group. What we're able to see is that lead and mercury readily transfer from the moms to the babies right through the placenta. And in most cases, babies have about twice as much mercury in their blood than the mothers do. These exposures resulted in negative birth outcomes. So that includes preterm birth, smaller head and stomach circumferences, lower birth weights, lower birth heights, things along those lines. But then when we compared the long-term data, we also saw that there were outcomes in early childhood. And of course, these also lead to lifelong outcomes. So there's a list here of different outcomes. I'm not going to go into detail at this point on those. Suffice it to say that right now, our current health limits are 5 micrograms per liter for mercury. And we've adopted the CDC's reference value for lead. So when we first started this project, it was at 5 micrograms per deciliter. Now it's at 3.5 micrograms per deciliter. So what's important to know is that the health effects can happen as low as 1 microgram per liter or 1 microgram per deciliter, respectively. We chose these limits because they were the lowest available, and because we're doing this diagnostically, we need to have something to point to. So the effects for mercury happen about 10 times lower than the effects for lead. Okay, most people are familiar with lead. I'm going to go into it anyway. It's a toxic metal that has been used for millennia. Currently, it can still be found in some older buildings in terms of the paint, in terms of the plumbing. Even though it's been banned in fuel, it's still present in small jet fuel, as well as in various foreign goods. Exposure is like most things, you breathe it in, you swallow it, you eat it or drink it, or you put it on your skin. There are some cultural practices that can increase risk to exposure. The use of lead containing pottery that's poorly glazed can leach a lot of lead into food. That can be, coffee mugs, it can be plates, it can be cookware. We've had examples of all of those. Cosmetics, things like bindi, kohl, and Sindoor and others contain lead. And the practice of eating earth. When I started this, I was not necessarily familiar with it, but it is basically eating soil from a parent's home country to try to connect that baby to the homeland. The messaging we give in that case is that, the connection's in the blood. You don't need to be eating soil that could be possibly contaminated with lead. This also makes it difficult to diagnose, and we'll talk about that very shortly. Ayurvedic medicine also has lead in it, and that can vary based on the culture, what type of products they use. Mercury I used to present as one metal because it's mercury. But the longer I've been in the field, the more I've worked with it, the more I've appreciated the need to break it out to 4 different types. And these are types that we can basically test for. There are a couple others out there that are that we don't test for, but these are the main ones. So methylmercury is the type that's associated with fish. So I mentioned the smoke coming from the coal plants or from wildfires that travels into the air. When it rains, gets into the ocean. Once it's in the ocean, the bacteria convert that to methylmercury. It is the most toxic form up here. And fish are in it 24/7. They absorb it anytime they breathe in water. When it accumulates in the small fish and they get eaten by the medium fish, then that gets absorbed by medium fish and by large fish and so forth. So there are fish advisories based specifically on this, but when we eat those fish, we absorb that mercury ourselves. And it does build up in the body. The half-life is approximately 30 to 45 days for mercury. Ethyl mercury is the type that's associated with preservatives or vaccines. I will say that we do not see it in our patient population. We don't see it in our statewide surveillance study, and CDC doesn't see it in their nationwide surveillance study. So we still test for it, but it doesn't really show up. So the good news is that as far as we can tell with the blood, our babies and our moms are not at risk to any sort of harm from ethyl mercury. Next one is inorganic mercury. Just like the other ones, it is toxic. This one's very heavily associated with cultural practices. So it's found just like lead in Ayurvedic medicine. Think cinnabar specifically as one of the major ones. It's also makes up the majority of the mercury in skin lightening products. So skin lightening products can work in one of three ways. One is mercury, which does a really good job of bleaching skin, but also does a ton of damage, attacks the kidneys, makes hair fall out, and does all sorts of other things. The other one is going to be steroids, which are not good for the body. And the last one is hydroquinone, which again is carcinogenic. And so pretty much there is no safe way to bleach skin. And I'll probably end up talking about that a little bit later as well. The last one is elemental mercury. This is a type that most people are familiar with, liquid type. I will say all these images are AI generated. I'm not having kids with mercury. These are found in, what's in the compact fluorescent light bulbs. So if one of these light bulbs here breaks, then there's a chance that mercury will be coming out of it. Dental amalgams, it makes up a very large part of dental amalgams. So about 50% or so of silver fillings is actually mercury. And it does leach out of the fillings, and it does expose people. We have in our statewide project, we measure for both blood mercury and urine mercury. Urine mercury is an indicator of inorganic or elemental mercury. And pretty much all but one of the people that have had elevated levels of mercury in their urine have had dental amalgam. It's used in goldsmithing. So as a hobby in this country and other places, there's gold mining, artisanal that really has a lot of risk. And also in religion. So there are some Afro-Caribbean, some Brazilian, and other Caribbean religions, I think Santeria, Voodoo, things along those lines, where it's used in various religious practices. It can be anything from spreading it on the floor of a new home for good luck or in a vehicle. It can also be actually injecting somebody with it. So those cases are more rare. It's also in Hinduism. Some of the prayer beads do have a large amount of mercury in them as well. So that's another way that people can be exposed. Lastly, I'll note that inorganic and elemental are volatile. So if you do, for example, get it inside the home, it's going to be in the air, it's going to get into products, get onto couches, it's going to get onto clothing and everything along those lines. So it's not an easy cleanup. Okay. So effects on adults, but I'm going to focus specifically on expectant mothers here. There's a nice long list here. And I put them together because I want to highlight these 10. And if an expectant mother comes into her doctor and says, I have abdominal pain, fatigue, difficulty sleeping, constipation, anemia, insomnia, nausea, vomiting, the doctor's first thought is not going to be, oh, you're clearly exposed to lead or mercury. It's going to be, these are normal pregnancy symptoms. Have a great day. And that is a problem with the diagnosis, right? So the next thing that they do is they give a questionnaire. Currently, we have a PRI, perinatal risk assessment, where the only question on there regarding lead or mercury was, do you live in pre-78 housing? Which is okay for lead. Really, it should be, have you ever lived in pre-80s housing, which they changed that question to, but there's nothing else on lead. And I just went through a whole bunch of different examples of where lead can come from, and there are no questions on mercury. So if the doctor doesn't know to ask these questions, they're not going to be asked, and risk is not going to be assessed. Further, if you ask somebody, do you eat dirt? Well, no, I don't eat dirt, right? In some practices, it's normal for, or in some cultures, it's normal for some people to consume earth to connect the baby to the homeland. Have you heard about this? Are you familiar with it? Yes, I have heard about this. Okay, well, that's a different conversation, right? So it's how you ask it. But then even, we've had cases where mothers have really, really high levels of mercury. The mother was eating earth and denied it, even though we found it in her blood. Same with skin lightening products. You can often tell when somebody's using a skin lightening product, and they will deny it up and down. And even though the data say, yeah, you are. I want to highlight another thing on this slide. If you're looking at preeclampsia, lead has now been linked as the highest risk factor for preeclampsia, as well as high blood pressure. So in New Jersey, especially at University Hospital up in Newark, where we're rolling out this program, about 40% of the patients have or a high risk or actually experience preeclampsia. So being able to better understand the links between chemicals and the outcomes in their bodies can help reduce some of these cases. Okay. Talked about adults, but we're really testing this to protect mothers and babies. So as I said, it goes through the placental barrier. When you're looking at lead on a child, that's why we do the child lead programs. We know about the neurological effects. They're even greater in babies and fetuses because they're more vulnerable and undergoing much more development and growth. So it affects the brain function as well as nervous system, does damage to different organs, affects bone growth. Throughout your life, when you're exposed to lead, it gets stored in your bones. And so it makes babies' bones more brittle. It also comes into play during pregnancy. I'll talk about that a little bit later as well. As I mentioned, increased risk of preterm birth and miscarriages. And then on the behavioral side, you have learning disabilities, lower IQs, aggressive behavior, and that can lead to lower educational attainment, lower career attainment, higher chance of living in a dangerous environment, and then the cycle just perpetuates again, and it's a multi-generational effect. For mercury, pretty much copy-paste, but again, at lower levels, and you still have the neurological effects. You also have the kidney failure, again, coming with the inorganic type. You have risk of blindness, microcephaly, deafness, and the same one for preterm birth and miscarriage. As a matter of fact, women who are trying to get pregnant and are eating a lot of fish sometimes may have such high levels of mercury that it keeps them from conceiving. Therefore, the advice is to switch to smaller fish because fish is still important for a developing baby, but the right fish matters. And then, 6 months to a year later, they're able to successfully conceive. And then on the right side, behavioral issues, same ones as lead. And again, that multi-generational effect is definitely a possibility. This picture is of a child who has Minamata disease. A lot was learned from methylmercury about the Minamata spill in Japan, where it got into the water, started affecting the cats who were eating fish, and started affecting people, and a whole generation, well, not generation, but a lot of babies were born with a lot of deformities and developmental issues due to that exposure. Okay. So we have all this knowledge. We did the work at Hopkins where we screened at birth and said, okay, why don't we do this in New Jersey? And why don't we do it at the first prenatal visit so that we can see if we can do some interventions and get these levels down before the babies are born? So we found some fantastic partners up at Rutgers Health who also work with University Hospital. And we instituted this as standard care. So we screen mothers at their first prenatal visit. And we also screen babies at delivery. So we have some educational materials that we give to all the mothers even before they get their results. We also have prescription for micronutrients basically prenatal vitamins here, but the ones that are highlighted do a really good job of mitigating the effects of lead and mercury in utero. So if you remember earlier, I mentioned there's a risk of the children's being overweight or obese if the mother has high levels of lead and mercury. That risk pretty much goes away if she has adequate levels of folate. So we also screen for all mothers at delivery, as well as all babies at delivery, as I said. The reason to get mothers at delivery is for those who don't get prenatal care or who got prenatal care outside of the hospital. This assures that pretty much every pregnancy is tested. We draw the blood as part of the regular blood draws for the mothers. For baby, we use cord blood. It's an excellent proxy, non-invasive. There's a ton of it. We do the analysis ourselves using ICP-MS. We can actually do mercury speciation. We're one of the few labs in the country that can do that. So that's basically a GC ICP-MS, triple isotope dilution. Okay. And there are additional resources available for the patients. So we have centering classes in addition to the education materials. We heavily endorse the use of doulas. They improve health outcomes. End of sentence right there. There are also local community organizations, your Green and Healthy Homes, and other ones that can help prenatally provide resources for expectant mothers. If they are diagnosed as being high, we have medical treatment. That was one of the key considerations is you can't tell a mother that she's exposed to lead and say, good luck. We thought about doing PFAS, a forever chemical. The messaging there would be, we don't necessarily know what it does. It can be inside you 8 to 9 years. The best way to get out of your body is to either donate blood or have a baby and pass it on to your baby. And we're not necessarily sure what it's going to do to your baby. That's not going to be good for the pregnancy or for the mother. So we've made the, in my opinion, very wise choice of not testing for it at this point. So we also have a diagnostic questionnaire to help the providers identify where the exposure is coming from. In New Jersey, the jurisdiction for child lead is with the local health departments. So we report cases to them. And then for adults, we have our CEOHS that can do both lead and mercury above 28. Now you've been listening, you hear there's a gap there because I just said mercury over 28. Our health limit is at 5 and the effects happen down at 1. So that's a gap that we're trying to address, but haven't quite gotten to the full extent of it at this point, but we're definitely working on it. And here's an example of our education materials. The one on the left is for lead, the one on the right is for mercury. These have been translated into about 11 additional languages, and we're also working on finalizing those so that they're available online. Okay. For treatment, CDC has put out guidelines for lead. Basically, 3.5 is that limit that we're using. And basically, the higher the levels, the more frequently you retest. And when you're getting up around 45 is where you start thinking about chelation. Pretty much the same with the babies. We have... We don't have these fancy things where I work. All right. So we have the same guidelines endorsed by AAP instead of ACOG in this case, and we do follow them quite well. We've had to chelate several babies so far. So how's it going? It's going actually really, really well. We started coming up on 6 years now, and have done, actually by now it's close to 25,000 tests, identified thousands of elevated results and even more exposures that are detectable and are in a range where bad things can happen. We've distributed materials, education materials to thousands of families, not only at the hospital, but through other providers, as well as community events and things along those lines. We do a lot of outreach through public health and medical education, as well as community outreach. Most importantly, medical environmental mentions have been implemented, and it's going so well that we're looking at third payer party options, and then we're actually expanding to other hospitals as we speak. And we've been covered by a few different organizations, CDC, Association of Public Health Labs, and various others have covered our work. All right, now's the fun part. Here's what we're finding. Looking at the mothers, we targeted Newark because of the well-publicized lead issues up there. The thing that we're actually surprised is that when we first started, as I said, that level was 5. So about 1% of the moms are above that health limit. And now that it's gone to 3.5, it's pretty much doubled to 2. Much lower than we expected. And then we sat back and thought about it and said, yeah, it is very well publicized. People know about it. When we go to events there, people come up to us and talk about it. They've ripped out the lines for the water lines. They have all sorts of different programs for cleaning up homes. And they have, Dr. Mona from out in Flint, who came out and talked to some committee members. They have a lot going on. They have a lot of knowledge of lead. We figured that elsewhere around the states, these numbers will probably be higher because people don't have all that attention and don't have all that funding coming in to address lead. Still, 24% of the moms are in that 1 to 3.5 range. On the mercury side, we were also a bit surprised. 4.5% of the moms are above the health limit, and that's for the first 4 years of our program. And about 45% are in that range where there could be some adverse health outcomes. Even more, yes.
Data, or is that the post-natal data?
This is prenatal.
So that's the one that should be elevated, mobilization from the bones.
So this is the first prenatal visit to be, so that could be at delivery, if that makes sense. Okay, so for we're doing chart reviews right now, and we'll have those data where we can see what mothers come in with, what they end up with, but it's going to be a little challenging for those that were elevated because we do interventions and it does come down. So it's going to be hard to say, well, the mother would have had this if not. So, but very good question. I'll show some data a little bit later on some specific case studies. So great news is for babies, that level is even lower for the ones that are above 3.5. It's about 1.5 or so. So at the low end, babies tend to have about 80% of the lead that the mothers have. Once the lead goes up, it actually goes up to about 120, 130% of what the moms have. So that's why you're seeing the numbers here. So only 12% of the babies are in that range that there could be adverse health effects, and another 1% are above the health limit. On the mercury side, you have double the babies that have that are above the health limit for mercury. I also take a step back and highlight that 60% of our babies have no detectable levels of lead, which is fantastic news. Back to mercury, so almost 10% of them are above the health limit, and another 50% are in a range where you can see adverse health outcomes. And again, about 10% have no detectable levels of mercury. As I've mentioned, we can do mercury. Again, I'll start by saying there is no ethyl mercury, so no risk from vaccines in this population. We see that while the moms are about 23%, 100% methyl mercury, the type from fish, babies are about 66% of that. That's where you see that 2-to-1 ratio come into play. So for the ones that are in the middle column here, that's still mostly methyl mercury, but have a blend of inorganic as well. Most of the moms fall into that category, and only about 30%, so about half the babies fall into that category. And then when you're looking at inorganic mercury, the type from dental amalgam, the type from skin lightening products, things along those lines, 10% of the moms have mostly that, only 2% of the babies. When it comes to the ratios between the levels in the moms and the babies, we do see that 2-to-1 ratio at the population level, as well as in individual dyads, with the exception of inorganic mercury. Inorganic mercury is more of a 1-to-1 ratio between mothers and babies. And so right now, where we're looking at percentages, we see mostly methyl going through, and it makes sense because methyl goes right through the placental barrier. The placenta can absorb some inorganic mercury, but not all. And that's where we get this discrepancy here. We're not sure of the physiology behind the 2-to-1 ratio. It could be something with the hemoglobin having a higher affinity for the 2+ charge. It could be who knows what. We're not sure yet. And we're not going to do clinical studies on babies to find out why. Okay. That was the population level. We can look at some case studies. So, and pardon the pun, but this is our poster child for prenatal screening. Mother comes in at 10 weeks gestation, so nice and early in pregnancy, has pretty high levels of mercury, 45 ppbs, parts per billion here. We did speciation on it, 95% methyl mercury, so that would imply fish. We did the screening survey. She says, I eat large fish, and she switched to small fish. And you can see throughout the pregnancy, those numbers plummet. At delivery, the number is down to 3.4. When we started this, people said, if you reduce the numbers in mothers, will it go down in babies? And we said, we don't know. So for a mother that's at 45, we'd expect the baby to be anywhere between 70 and more likely closer to 90. And we were thrilled to find out the baby was down 7. 7's still higher than we want, but it's much lower than what it could have been if we didn't have interventions. So interventions work. Those levels come down. All right. This is the case for screening at delivery. 49.5 micrograms per deciliter of lead in the mom. Baby had 65. This is one of those cases where it's crossed that sweet spot where babies tend to have more lead than the mothers. Unfortunately, no prenatal care at all for this mother. She was foreign-born. She had some language issues. If you go back to the disparity slide and causes why, she had transportation issues. She did not know about the services available to her in New Jersey, despite being undocumented, and did not get any care at all. We phoned this result into the hospital immediately, and the baby had already been discharged. Newark police had to pick up the baby and bring it back to the hospital because, again, she didn't have transportation issues. We tested the breast milk. It was high for lead, so we advised that they use donated breast milk, which they did, and they chelated the baby that same day. Turns out she had been eating earth, and once the baby's levels got down below 30, they were able to release it from the hospital, continue tracking it. The levels kept going down. It's now below 3.5, which is good. The baby did face some developmental issues. One of the great things about this program is that Rutgers Health and University Hospital, for any baby that's above the health limit, goes directly into an early interventions program. And that baby is coming along very nicely. We've seen some marked improvements over the last year or so. That's the other thing. Not only do we have to have support for the mothers, we also have to have support for the babies. Okay. Next one. This is a lead challenge, where we talked about lead in the bones, and that's what you were referring to earlier. We had a mom who came in and at 33 for her first test, got a second one, and it was 43.7. This baby was born preterm. You can see where we basically got talking to her, and those levels started coming down. So you saw 28.2, 22.8, and then a spike at the end. So one of two things, we're guessing probably both happened, is that one, lead coming out of the bones, because there was a lot there to come out. And the second is she may have slipped back in her behavior as well. The good news is for the second baby, she came in later, but that baby started off much lower. You can see that little spike going up at the end, but instead of being, double up to nearly, 45, it stayed up around 21. So the second baby was born with half the level of lead that the first one was. But we'll never see that almost complete reduction that we see in mercury, unfortunately. And this is also why it's so important to understand the mother's lifelong history when it comes to lead exposure. Okay, so I mentioned we do the screening at the first visit and at delivery. The reason for that is because I started with a $25,000 budget. So while we would love to do, urine testing for mercury, and we'd love to do prenatal screening at each trimester, it just wasn't going to happen. So the mom came in her first delivery, first pregnancy, pretty good numbers actually, 1.5, nice and low by the time she delivered, 1.38, and got down a little bit. Baby could below 1, barely detect anything in it. Second baby, she came in at 0.57, and our detection limit is 0.5, so we were very happy with this. And then nothing for the entire pregnancy, and then she delivered, and we did that screening at delivery, and her numbers were up to 36, and the baby was at 34.1. She moved 3 times during her pregnancy, the second one. So housing instability one of those disparity causes. During the move, the box that had her plates in it was dropped. They shattered. She got a new set that was poorly glazed pottery. And every time she ate anything, she was poisoning herself and her baby. This baby had to be flown to New York for emergency heart surgery. First baby was perfectly healthy. This one had some serious issues. The only difference between the pregnancies that we can see is the higher levels of lead.
Where do the plates come from? Is it imported or is it like sold in general stores?
Yeah, I mean, they can come from all over the world, often imported. For the most part, it's if it's not poorly glazed, I mean, if it's not well glazed, then there's a risk. We've had a mother that was drinking coffee out of a poorly glazed mug, and her numbers were up in the 80s because coffee is acidic and the acids love heavy metals. And so it does a really good job of leaching things out. So the more acidic the food, the more frequently used, the poorer the glaze, the higher the risk of exposure. Okay. I mentioned we have done some retrospective chart reviews. This is for the first year. We did some cherry picking here. We did the mothers and babies that were above the health limits and compared to those that had no exposure to either lead or mercury. So for these data, you should keep in mind that this is going to be probably 90% mercury, 10% lead. And we found a couple of things that really stood out. One is that the mothers that were elevated tended to be about 7 years or so, 6.5 years older than mothers that had no exposure at all. The other one is that 75% of the mothers that are above the health limit are foreign-born, as opposed to only 20% of the mothers that have no exposure at all. So we identified a really important risk factor here, which helps us target our education with our limited, public health resources. At the same time, it's a big risk factor, but it's not the only one, right? There's still 25% that are not foreign-born, and there are other causes besides just being foreign-born. There's poverty. There's all sorts of different risk factors here. Looking at the babies in terms of outcomes, we see that there are three that really stood out. The one's not on here. Basically, APGAR scores were significantly lower for exposed babies, both at 1 minute and 5 minutes. But the ones that really stood out to me were that babies who are exposed in utero are 75% more likely to end up in the NICU. And they're also 6 times more likely to have an abnormal newborn screening hit. At this point, we don't have sufficient data to pin it to a specific disease. However, we're hoping as we get more data out of the systems for the last 5 years, we're going to be able to narrow it down to specific ones. I want to highlight that it's not like 0.06% to 0.36%. We're talking about 5% and 31%. So 3 out of every 10 baby who has an elevated level of lead or mercury is going to end up with an abnormal newborn screening hit. Okay, I'm going to throw in a bonus case just for fun. This is from our surveillance study. This participant had high levels of blood mercury and had a little bit in her urine. And when we did the survey with her, we found out that she had large fish and encouraged her to switch to smaller fish. And so the numbers went way down when we tested a little bit later, which was great news. And we tested the speciation, and we were able to see that not only did the methyl mercury go down, but the inorganic mercury went down as well, which is great news, except when we look at her urine, that number went up. And at that point, I hadn't been to the conference yet. We learned about dental amalgam. And so we actually called in she also had some thallium exposure as well. So we called in our poison center to consult with her. The likely causes here is that it's probably coming from her dental amalgams. And the thallium is probably coming from cruciferous vegetables. So, but even when you solve one, it's not necessarily the full picture. And this was a valuable lesson. Again, this highlights that mercury is more than one chemical. Because while total mercury, we can tell you, and we can tell you the breakdown, she was still being exposed through other sources of the inorganic one. Okay. So what this all means, if you ask me, it's a very efficient tool. It's proactive. It identifies cases that would have otherwise never gone diagnosed. I'll go back to that mother that didn't get prenatal care. The same obstacles that prevented her from getting her prenatal care would likely prevent her from getting her child to the 12 visits. So where we would do child-led testing at 1 year old and 2 years old, I can't tell you what the odds are of that child being there, but I can tell you it's not 100%. Secondly, not all doctors' offices have the ability to do the child-led testing in-house. They don't all have lead care systems. They farm it out to LabCorp and others. So it's another trip that mother who has no transportation has to make, has language issues, has to make. Third one is LabCorp has limited hours. So they tend to be the hours that we work. And so if she doesn't have sick days or that, and she has another obstacle she faces. So there's a good chance that this child would have never been diagnosed, even later in life, for other lead sources. Here, we're able to get in, educate the family, get that knowledge in there, and ideally get that so that when, if it does get to those well visits and get tested, we see those numbers are lower. Second thing, that child is tracked as a high-risk child by our child-led program, and is now on the books for the local health department, and they can follow up with them at any point and make sure that that testing is being done. And again, gets into early intervention, right? So there's a lot going to support there that would not happen if not for a simple prenatal test. And this one is actually at delivery, right? So we've identified a potential concern for mercury in New Jersey that we weren't aware of previously. And other states have seen this. So the Hmong population and the Somali population out in Minnesota, we have the Asian Pacific Islander population in California, the Hispanic population, and others in Texas as well. So, California to Jersey, New York, up, down, Texas to Minnesota, coast to coast, right, border to border. As I said, it's proactive, and there's a really high return on investment, and I'm going to get to a slide that shows that a little bit later. Realistically, at cost, if you have the instrument and an analyst, then it's a few dollars per test. Okay. So what about communities? Typically, we don't want to read it out, but I will. They're probably not aware of the risks, right? They're probably being exposed, and they're probably facing adverse health outcomes. And they're not being treated, they're not changing behavior because nobody knows about it. I mentioned Newark. It's a relatively heavily Black and Hispanic population. University Hospital itself is about 98, 99%. Going back to that stat of women of color being 60% more likely to face maternal mortality and other adverse health effects, that really comes into play here. Places like Trenton is a copy-paste of this. New Jersey in general, we're about 9 million in population, a bit more spread out in terms of diversity. You'll notice 10% of New Jersey is Asian. Women of childbearing age of Asian descent tend to have about 3 to 4 times higher mercury levels than the general population. Poverty plays a factor in it. And as well, we talked about the foreign-born status. So a quarter of New Jersey is foreign-born, second to only California. Some cities like Hackensack and I believe Plainfield and others are higher than that, at 40%. Looking right outside the window here at Philly, 34% Black, 15% Hispanic, 8% Asian, 22% poverty, 15% foreign-born. So I would say that it's very safe to surmise that there is some risk happening right here that's not being tested and treated. Okay. To allow time for questions, I'm going to just focus on the right side of the slide. The picture in the middle is a girl that was exposed to inorganic mercury, facing muscular hypotension. I believe, and I don't recall, but this may have been from there being skin lightening products inside the home. So on the right side, you see exceedances of 5 micrograms per liter. That's what we're using for the health limit. NHANES is a CDC's national study, surveillance study for all sorts of chemicals. They're seeing about 3.3%. The way that NHANES is carried out is they randomly choose 15 places throughout the country over a 2-year cycle and go there and test whoever they can. It depends on where they go, right? It definitely is not indicative of any state, and it's not a full indication of risk. Our moms are about 4.5%. Our babies, as we saw, were about 9% above that health limit. Our statewide study shows that about 11 to 12% of our population is above the limit. You would probably double that for babies, and that would put the babies, again, about a quarter of the babies being born in New Jersey above the health limit. And that's not even talking about that range between 1 and 5, where 50% of the babies up in Newark are. So, the slide's not big enough to fit that on here in terms of the risk in New Jersey and likely elsewhere around the country. Okay. We do have screenings currently in place that are universal, right? We have child-led screening at 1 and 2 that I mentioned. It is recommended to be universal, not necessarily implemented so. Some of the feedback from providers is this is a one visit where the child does not get a stick. We don't want to do lead and make it an unpleasant visit for it. There's no routine screening for mercury in children. Okay, prenatal, we do, STIs, we look at iron, we look at all sorts of different things. There is some risk-based, but we talked about what that risk-based looked like. And newborn screening, it's, metabolic testing to see what's going on there. It's usually about a day or two after delivery. And New Jersey is actually pretty good at that. We're one of the best programs in the country. How's it compare? All right, this is the ROI we're talking about. The cost of the test is a couple of dollars, and the risk. So we're looking at maternal morbidity. These are national numbers. About 8% of pregnancies experience gestational diabetes, and 3% preeclampsia. That's the peachish color. In green beside it, we have STIs in New Jersey. So about 3% chlamydia, 0.25 gonorrhea, syphilis at 0.01. And then the ones here at the complete right are your newborn screening ones. You look at 1 in 1,200 for the most common one, congenital hypothyroidism, looking more at 1 in 200,000 for the rare ones like maple syrup urine. And then you look at our screening, and lead, 13.6% of the babies at that hospital are at risk of adverse health outcomes, and another 50 or 60% for mercury. So one of the reasons why the other ones are so low is because we test for them routinely and find them. And you can see the difference between lead and mercury. So lead is, in my opinion, a public health success story. 93% reduction in lead over the last several decades. We should highlight, though, that that's not an equal lowering across the board. There are communities that are much more affected, where the screening rates are closer to 40%, and where the prevalence rates can be, 7 or so, even higher percent of children above the reference value. So these are the same communities where you're likely to have higher exposure to lead, where you're less likely to have access to healthcare, where you're less likely to have access to public health services. One of the things that we are doing to address that is we're trying to repurpose our COVID vans into mobile testing vans. So we can put some lead care systems inside the van, drive to these communities, and offer lead screening to expectant mothers and children on the spot, and ideally take some venous samples back to the lab to test for lead and mercury, and maybe even PFAS and other chemicals. We are waiting to get those instruments. Once we have them, we'll validate them and be ready to go. The vans belong to our micro folks, who will also be able to, and are currently converting them to do STI testing as well. So, okay. We'll go over a few public health gaps. So for lead, we do have a reference value from the CDC. We don't have that for mercury. We have some nice policies and guidelines, right? I talked about the follow-up testing, things along those lines. Universal screening. Really no universal screening for mercury, and there's not really part of child-led policies. It's kind of absent there. Medical treatment protocols, right? The chelation, the follow-up in terms of that is well established and really consistently applied. There's no real intermediate treatment protocols for mercury. Some states chelate, some don't. Some states, have tracking programs, some don't. Most don't, I should say. So for tracking programs, we have child-led programs. There's federal and state funding. Environmental protocols also are well established, cleaning up a house, right, remediating it. And HUD has funding to do that. Really kind of lacking on the mercury side. There are some states that have some funding, but it's very limited. There's, we saw that mother who had 45 micrograms per liter of mercury from fish. That was so easy. Just switch a small fish, done, right? If a mother has a ton of exposure from skin lightening product, it's on her clothes, it's on her furniture, it's on her bedding, it's everywhere. And to do that cleanup is going to be anywhere from $30,000 to $100,000 to get that out of the homes. There are some home protocols, but they're not necessarily endorsed by anybody. But California has a document that if you can't do this, if you can't afford this, this is something you can try on your own. It gets much more challenging when you're looking at people who are renting, people who are concerned about status or whatever it may be. Same on the lead side, I should point out. Okay, there are also product bans. So we know lead is banned in gas, lead is banned in paint. It's, there are limits on what can be in baby foods, things along those lines. And it's actually going in the right direction. There's guidance for fish, but that's about it. New Jersey does have a ban on fever thermometers. Other thermometers can have it. So, and it's surprisingly way too easy to get access to mercury. Okay, so what we can do, we can learn more about these risks, share this knowledge, and have constructed dialogues about alternate practices, right? This comes for skin lightening products. This comes for religious use, to really educate people about the risks. The challenge for skin lightening products is that there is a societal cost. There is a often financial cost to having darker skin. There's no argument about it. This stems from colonialism, this stems from colorism, this stems from racism, and there is a cost to not using skin lightening products. But we have to basically educate people and let them know and let them make an educated and informed decision on whether they're going to discontinue use or not. We're doing professional outreach. We would love to see a reduction both for demand and supply of harmful chemicals, so some bans going into place. And see some more screening policies, right? Maybe really just look at not only pre and perinatal screening programs, but adding mercury to child lead testing all women of childbearing age, so that we can address some of these things before they even think about conception. Okay, and making people aware of the resources. So this can't happen without a ton of people supporting our program that we are extremely grateful to have. And I'm happy to answer any questions.